Welcome to this video on Global Perinatal Mental Health Part 1, Prevalence and Presentation. I'm Amrita Bhatt. I'm a perinatal psychiatrist, which means I provide clinical care to individuals with mental health concerns in pregnancy through 1 year postpartum. And that also includes people who are struggling with infertility or pregnancy loss. This lecture will focus on global mental health with case studies of women's mental health and perinatal mental health. Here is what we will cover in this video. I will summarize how the prevalence and presentation of perinatal mental health symptoms can vary across cultures and the risk and protective factors for perinatal mental health problems across cultures. This is similar to global mental health in general. You're all familiar with this disability-adjusted life years. If we look at both sexes and all ages, the ranking of mental health for DALYs rose from 1990 to 2019. Focusing in on females, it rose further. And then if you look at females in the reproductive age, that's 15 to 49 years, it has consistently been the highest cause of disability-adjusted life years. Focusing on a specific mental health condition, the most common diagnosis, major depressive disorder, when you compare the rates of major depressive disorder between females and males, you can see that there is a significantly higher rate in females. This particular study illustrated here was conducted in the United States, but this pattern holds true across countries and across settings. As you can see from the graph, the prevalence of major depressive disorder is higher in females beginning around the time of puberty, remains elevated, followed by a spike in the reproductive years, that is the 20s and 30s. There is a further spike around the time of menopause. This difference in prevalence is attributed to the fact that the physiology of women is different, with very specific hormonal changes. However, other factors are equally important, such as the context in which people live, violence against women, reproductive rights, the stress of caregiving, and childbearing. Zooming in further on the prevalence of mental health problems in women of reproductive age. This is a cohort study of about 55,000 women 2 years before and after childbirth. As you can see, the average number of psychiatric hospitalizations, so indicative of a severe psychiatric illness, per month is 7 times higher in the month after childbirth and remains high for 1 to 2 years after childbirth. In a woman's lifetime, that first year after delivery is the highest time of risk of having major depressive episode and being psychiatrically hospitalized. Luckily, there are many opportunities to intervene with 10 to 12 antenatal visits and several postpartum visits and well-child visits. We have these opportunities to intervene. We also have research, this is mostly from the global north, that helps identify risk factors for increased rates of depression or other psychiatric conditions. A past history of depression, current depressive symptoms. These are true of any population. And then if you look at the perinatal population, being an adolescent, a single parent, having experienced recent intimate partner violence, elevated anxiety symptoms, and adverse life events are all risk factors. Let us transition to discussing clinical presentation of mental health symptoms. This is our first case example. A 30-year-old married woman 6 months postpartum with a 3rd grade education, experienced interpersonal violence or IPV from her husband who abuses alcohol. She has suffered from headaches for several years. She is able to function, does all the household chores and cares for the children, but has difficulty sleeping, persistent fatigue, and headache. She has received treatment from all the local religious practitioners and from the primary care physician who visits the health center in the neighboring village, but with no relief. Usual treatments for headache have not been effective. Major depression is one possible explanation for her symptoms, given her reports of stressors and fatigue. The Diagnostic and Statistical Manual of Mental Disorders lists psychiatric diagnostic criteria and lists the core symptoms of depression as little interest or pleasure in doing things, feeling down, depressed, or hopeless. Although she did not present with these complaints, but rather with headache, These core symptoms of depression did come up on further interview and discussion, and she received a diagnosis of major depression. That is an example of how clinical presentation can vary based on a person's culture and context. For example, in several Asian cultures, psychiatric symptoms are often somatized, which means they present with more somatic symptoms, such as headaches and body aches, and symptoms of psychological distress are revealed on further evaluation. In terms of treatment, in addition to antidepressants and psychotherapy, psychosocial interventions are equally important, as in this case, the need for attention to interpersonal violence and husband's alcohol use. As an example, let us use postpartum depression or major depression in the first year after childbirth. So, thinking about depression in the postpartum period, there is often a discussion around the fact that since all of this diagnostic data was validated in a Western population, is this just a Western phenomenon? But we look at depression in the postpartum period, and we find that it's pretty prevalent across the globe. The prevalence ranges from 3 to 26%, depending on where you look, but it is present in all countries. It just might present differently. These are the different idioms of distress, or how people present with their distress. Sometimes people describe this feeling of sadness or loneliness that we know of as depression, as their heart being squeezed, or they might present with exhaustion for which there is no detectable physical cause. People might describe anxiety as ants creeping the brain. So it's important to keep all of these different reports or manifestations of psychological distress in mind when we are assessing mental health symptoms. And just as risk factors vary, protective rituals differ across countries as well. For example, here are some of the postpartum rituals or pregnancy rituals: having baby showers, going to childbirth classes. And these have the indirect purpose of shoring up social support, which is protective of depression. In other countries, there are rituals like quarantina or doing the month, in which the birthing individual is given a full month or 2 months of staying home, not needing to do anything except feed the baby. Everything else is taken care of for them. So really a time of rest and relaxation, which has been shown to reduce the risk of postpartum depression. In addition to risk factors being different and the presentation being different, help seeking is also different across cultures and across countries. There are several cultures in which people accept what they're going through as fate. The patient we discussed earlier, who came in with headaches, had actually endured these headaches for several months, thinking that it was her fate, that she had sinned, and this is why she was being punished. People might try religious rituals to help with their symptoms. People might perceive treatments as being ineffective, which does influence treatment seeking, taking the treatment regularly and also response to treatment. Women may depend on their husband for transportation and finances, or they may feel stigma. That can influence health seeking as to when and whether they're able to come in and seek help. All of these factors lead to differences in patterns of help seeking. Here is another case example. She came into the emergency room saying, "Someone did something to my uterus." She is a 35-year-old woman born and raised in Somalia, moved to Seattle 15 years ago. A month after her 5th child was born, her concerned family brought her into the emergency room because she has not been eating, sleeping, or holding her baby. Here are the different perspectives of the clinical team that ended up caring for her. So the patient came in saying, and her perspective was, "Someone did something to my uterus. Something's not right." The obstetrician who saw her, because she was postpartum, might be thinking this is a 37-year-old grand multipara. Grand multipara is an obstetric term for someone who's had 5 or more births. Advanced maternal age, G7P5. G refers to how many times this person has been pregnant. P refers to how many viable births the person has had. 4 weeks postpartum. So the obstetrician is concerned that the patient is at high risk for things like postpartum hemorrhage or preeclampsia. She has difficulty with breastfeeding. She has ketonuria, which indicates starvation. She also sees from the chart that this person has had multiple somatic complaints throughout the pregnancy and has missed several of her prenatal appointments. So the prenatal care wasn't the highest quality, and that's a risk factor for postpartum complications. The psychiatrist was thinking, well, she has no past or family psychiatric history, so she doesn't have that risk factor. But this thing she's reporting about someone doing something to her uterus, is that a psychotic symptom? Is it a false belief that she's holding, that she's not in touch with reality? Or is it dissociation? From a safety point of view, if she doesn't want to be admitted to a psychiatric hospital for treatment, does it warrant involuntary treatment assessment? Is there a concern for the safety of her children if her symptoms interfere with her ability to care for them? And should Child Protective Services be involved? The family is worried. They're saying she's never been like this before. They're saying, well, I don't know why you want to give her medication. I don't think that's going to help with this. She is suspicious of her husband, which is very concerning to us. We think she has been possessed by an evil spirit and she needs religious treatment. Just get her to eat or give her some IV fluids and we'll take her for religious treatment. An anthropologist would be thinking about her cultural identity, about what are the usual idioms of distress in her culture, what are her vulnerabilities and resilience, and what is the cultural patterning of the postpartum period. If she were back home in Somalia, would her postpartum period have looked different than it did here? Some of the things that we keep in mind when we're assessing mental health in people from different cultures and backgrounds and context is the fact that the range of what we call normal belief differs across cultures, and it is important to ensure that when someone presents to us with something that is not familiar to us, that we understand the cultural context of their symptoms and whether their symptoms are culturally congruent. So what are the features of a culturally congruent symptom? There is community and family support for that symptom. In this case, her family was saying, yes, this happens sometimes to women in the postpartum period. They get possessed by an evil spirit and they feel like something has been done to the uterus. The symptom is limited from a few hours to a few days. There is socially appropriate and productive behavior before and after the experience. And there is the absence of other psychopathological signs and symptoms, which in psychiatry would be things like hearing voices or seeing things. She was reporting somatic symptoms throughout her pregnancy, which turned out to be the beginnings of a depressive episode. In her case, she did end up needing psychiatric hospitalization just because she had severe depression. But that belief that someone had done something to her uterus was not a psychotic symptom. We were able to allow the family to bring in a priest, and they did the religious ritual that they wanted to, and she got better with the combination, we think, of our treatment and the religious ritual. In summary, this video covered prevalence of perinatal mental health symptoms, the clinical presentation of perinatal mental health symptoms, and how risk and protective factors for perinatal mental health problems vary across cultures.